Thank you for letting me share our humble work. And our objectives will be uh, first, review the use of aminophylline intraoperatively to improve the postoperative kidney function and urine output. And then we're going to discuss the utilization of machine learning algorithms in real time to predict risk of postoperative acute kidney injury. Then we're going to jump to the use of predicting postoperative urine output using data from intraoperative and early postoperative periods. And finally, we will review the use of early postoperative peritoneal dialysis for newborns who qualify as high risk for acute kidney injury. And just to get all of us up to speed, cardiac surgery in the newborn and the young infant is commonly complicated with acute kidney injury, up to 50% of the cases. And about 5% of the cases require dialysis due to intense and protracted renal failure with fluid overload issues, which increases morbidity and mortality. And all this, both the kidney failure and the fluid overload, negatively contributes to the overall outcome of the patient due to prolonged ICU stay, increased ratio of mechanical ventilation, and higher infection risk. So now with the new improvements in the surgical techniques and the postoperative care, the risk of mortality overall for pediatric cardiac surgeries is less than 5%, whereas the risk increases up to 50 to 80%, those who require dialysis in the postoperative period because of intense renal failure. So with that in mind, what we try to do is first, during the cardiopulmonary bypass, it is not uncommon for kids to shut down their urine output, which those of which who went into the operating room with normal kidney function and good urine output, thinking that this is probably a functional problem, not a structural problem at that point, and try to switch to a new treatment, aminophylline, instead of the furosemide. And what we have seen when we used aminophylline versus furosemide in the operating room is that in the first 8 hours, the urine output increased compared to the furosemide group in those kids, not reaching statistical significance in this 100 per arm group, but in a larger cohort, it may, which did not improve its urine output increase when looked at 48 hours. But is importantly, we noticed that when aminophylline was used, the dialysis requiring renal failure significantly decreased compared to when furosemide was used in the during the operative period, which may give a significant advantage for these kids. And the hypothesis is that this is due to the tubuloglomerular feedback mechanism on the single nephron GFR strategies that relates to the vasoconstrictive and vasodilative activities at the glomerulus. From that point on, we decided to see if we can define more granular and more detailed risk stratification for postoperative kidney failure using machine learning. And what we have seen that in this mean SHAP values that yes, preoperative serum creatinine is the highest risk. However, there are many factors that come as risk. For example, pH of the patient, serum lactate level, serum hematocrit, and the urine output in the first post-op 8 hours, all of which are related to the immediate post-op period, not as the predeterminant of the pre-surgical demographic data, or not even what happens in the surgery. So suggestive of maybe these intraoperative data coupled with immediate postoperative data may give us very or more precise prediction of acute kidney injury risk. And the risk the stratification here is again depends on longer surgery time, lower pH, and elevated lactate as the distribution direction of impact on the SHAP values. Um, Now, what is very helpful, which may also be helpful at the bedside, because these machine learning strategies can be individualized as to which part of those risk stratifying predictors uh, contribute to the overall risk in a single patient. As you see, there are two patients demonstrated here, that one without acute kidney injury and one with acute kidney injury, and how the different predictors that they are all being defined by the machine learning contribute to that specific patient, helping the clinician at bedside. The third thing is, we said, can we predict the urine output in the first 1 to 1.5 day, which is very important rather than waiting and seeing the outcome. And what we did was we used our initial data set and using the weight of the patient going into the surgery, the hematocrit of the patient coming out of the surgery, the cardiopulmonary bypass duration time, postoperative pH, vasoinvasive score, and the postoperative cardio CVP, we were able to develop a formula with addendum of some constants. And as you see here on the second work that we have completed in means of predicting the postoperative urine output in the 32 hours, and you see here we have the patient's urine output, and on the y-axis we have the predicted urine output with a very good prediction, and most of the patients being predicted pretty well with a reasonable margin of error there. Can we predict the ones who will require peritoneal dialysis in these newborns and very young infants? And when we looked at our data, what came out that immediate postoperative mean arterial pressure is the standalone predictor for predicting early peritoneal dialysis. And when you look at the different predictors, contributing age not really was significant. The urine output wasn't really all that standalone significant. Mean arterial pressure significantly decreased the risk of early peritoneal dialysis when it was more than 48 millimeters mercury. And depending on the aorta cross clamp time during surgery and the cardiopulmonary bypass time, these are the 50th percentile for these interventions during surgery. The risk significantly increased 1.7 times for aorta cross clamp time increase and 1.5 times for cardiopulmonary bypass time increase. And finally, well, does this really make a difference predicting them? In a way, yes, for two ways, because this is the fluid balance outcomes in the first day, second day, third day, fourth day after surgery. And the gray line are the ones who were predicted to have peritoneal dialysis early in the post-op period, and the dotted line is the ones who responded to diuretic therapy very well. And as you see in the first day, those who respond well to diuretic therapy with better urine output, that is more negative urine output, progressively got more negative urine output that achieved their fluid balance much better, and they did not need it, and they balanced it out and at the third day onwards. However, those patients who did not achieve a negative fluid balance and needed to achieve that, and that was the prediction for peritoneal dialysis, was able to have comparable fluid balance with this help of peritoneal dialysis. And this is not a randomized study, but in the absence of which it could have been that these patients had developed more fluid overload. Similarly, the urine output, this is the urine output data for those two cohorts who got the early peritoneal dialysis and who responded well to diuretics. And as you see, this is the immediate postoperative 8-hour period, and this is the 24-hour postoperative period. You see that in the first 24 hours, the ones who do not need peritoneal dialysis significantly differ from the ones who require the peritoneal dialysis, using urine output as a dynamic biomarker at the bedside. And the serum creatinine, which is a very common method of evaluating these kids, are demonstrated here that starts to be helpful only as early as the second to third day in the postoperative period, which is much later of an intervention. So, what may be some of the suggestions out of this is that maybe intraoperative aminophylline may prevent or ameliorate dialysis requiring postoperative kidney injury in the high-risk newborns. Machine learning algorithms may be the future of predicting postoperative severe acute kidney injury. Intraoperative and early postoperative predictors may have higher sensitivity and specificity in predicting severe AKI compared to previously described markers such as demographic markers, type of cardiac injury, type of cardiac defect, and type of surgery. And early post-op period, the first 24-hour clinical and laboratory predictors may be game-changing in detecting those newborns and young infants who may benefit from early PD. And with that, I will stop.